Hello and welcome to IDF Europe's World Diabetes Day Symposium on access to diabetes care, if not now, when? The topic for today is how are digital technologies and AI improving access to diabetes care? This event today is co-hosted by MEP Sirpa Pietikäinen from Finland. She is the co-chair of the MEPs Mobilizing for Diabetes Interest Group in the European Parliament, and by MEP Marisa Matias from Portugal. Thank you very much for being here with us today. As you all know, Sunday was World Diabetes Day. Sunday, November 14. It is the birthday of Sir Frederick Banting. 100 years ago, he celebrated his 30th birthday, and just a few weeks before, he made the discovery of that saved people like me, people watching right now, hundreds of millions of lives around the world. He discovered insulin 100 years ago, so it would have been his 130th birthday today. And this is why we're gathered now, 2 days after World Diabetes Day. The centenary of insulin, so the 100-year celebration of the discovery of insulin, is the overarching theme, or the overarching theme is actually access to care on the occasion of access of this discovery of insulin 100 years ago. It is the theme for World Diabetes Day, not only this year, but for the next 2 years as well, access to diabetes care. The reason behind, there is some 59 million adults, or 10% of the population living with diabetes. It's forecast to increase to 66 million by 2030. And people with diabetes require ongoing care and support to manage their condition and to avoid complications. And equitable access to treatment needs to be guaranteed according to the most up-to-date evidence regarding benefits of medicines and technologies, including newer alternatives that are now coming to market. And to ensure equitable and sustainable access to quality care, it is now time to really rethink about how this care is being delivered. It is time to move from reactive to more proactive care delivery and towards more individualized care. And these are all topics that we want to discuss today here during this webinar. New technologies, digital technologies, and the use of artificial intelligence will play a major role. Now, it is my great honor to very shortly introduce MEP Marisa Matias, like I said, the co-chair for today's webinar. She has been an MEP from Portugal since 2009 and is part of this MMD, or the MEP interest group in diabetes. I will then have Niti Paul, chair of IDF Europe, or president of IDF Europe, give her opening remarks. And then we have 3 amazing speakers for today. We will start out with Javier Paul. He is a type 1 advocate for diabetes. He's also co-founder and CFO of Harbor and a digital health entrepreneur. We will then be joined by Sufyan Hussain from King's College. He will talk about the role of digital technologies and AI in supporting clinical decision-making and driving personalized diabetes care from a healthcare professional perspective. Sufyan is a specialist in diabetes tech and in the clinical application of artificial pancreas systems. And he also lives with type 1 since more than 25 years. And last not least, we will have Luke Slavomirsky from the OECD. He's an expert in e-health, digital transformation, and health data governance. He's currently based in Australia, but has worked in Europe for many years. And he will talk about the role of digital tech and AI in addressing population health management for diabetes care. So with this, I would like to hand over first to Marisa Matias. Oh, and I forgot, Sirpa Pietikäinen from Finland, the co-chair actually of the MMD interest group, will of course give the concluding remarks before we end with Nipo Seladic, our co-chair. But let's start now with MEP Marisa Matias with her introduction and opening remarks on the centenary of insulin and the health priorities in the European Union. Marisa, thank you for joining us.
Thank you so much, Bastian. And I want to welcome everyone in this session and thank all our speakers who will take the floor and help us to think about the way ahead as we really need to have your inputs and your experience. As it was said already, this is a very special year. We are talking about the centenary of insulin. And also that could be a good landmark in order that we could change and start change the way we approach diabetes in order not only to have more devoted policies as well as more coordinated policies. And we know and we saw, because of the figures that were released just recently, that the figures are increasing. And in the case of people living with diabetes in the world, it was an increase of 16% if compared to the figures of 2019. So there's a lot of people who need our intervention and who need that we think about diabetes as a priority. We have been fighting in the parliament since a long time now to put diabetes in the center of the politics. I mean, to give health a priority in the European Union. Some things were already achieved, but we are still far away from the concrete needs. And so we would like to continue to make these efforts in order to make diabetes not only a priority, but the way we treat diabetes, the way we deal with diabetes, paving the way for transformation of the health systems. We have seen several proposals in this direction. I recently, and only this weekend, while we were celebrating the World Day, José Manuel Boavida, you know him very well, wrote a wonderful paper in the Portuguese newspaper talking about these priorities and these needs. And of course, with the claim that we all do now, which is if not now, when then, and that's why we are here together. I don't want to come into the content because that's your part in this in this conversation. I just want to welcome you all, and I'll be here and listening from you and learning from you. And I hope that we can keep continuing this work together and that we see changes in the near future in the European Union. Thank you so much.
Marisa, thank you very much. And it is, of course, very important that you and your colleagues are here. It is great to have this interest group of MEPs mobilizing for diabetes. Our aim here at IDF Europe and the many partners is to have, on average, 10% of the MEPs in the European Parliament eventually joining that group, which would resemble the number of people with diabetes worldwide of the overall population in Europe. That would be great. So thank you very much for joining us here today. We also already have first comments in the chat of people thanking you also for your work, for supporting IDF Europe and supporting the cause of people living with diabetes around the world, especially in Europe, of course, and especially on this day. So as you were saying, thank you very much for joining. And yes, it is IDF Europe's role to push the agenda forward. And I now give the word to Niti Paul, President of IDF Europe, to introduce the topic further. Thank you, Niti, for joining.
Thank you, Bastian. Good morning, everybody, and good afternoon to some of you. It's still good morning in the UK. I really warmly would like to thank Sirpa and Marisa for all their support and all they do in the Parliament for the cause of people with diabetes. So thank you so much. Again, heartfelt thank you from all the people that you help advocate for. Thank you so much, both of you again. And today, our topic, we've done lots of webinars, and Bastian and I have been on another one on the weekend. We did lots of those back to back, lots of activities, lots of community events. But it's been so. But we are looking forward, and we are looking forward to the next 100 years. And what do we find that's been happening in the world of diabetes and other chronic diseases? Is the role of technologies, new and innovative therapies that are coming out to make the life of people with diabetes better. I'd also just like to raise a few challenges that we have across Europe that we found as we advocate for people with diabetes. We've got decreasing number of diabetologists and general shortage of healthcare professionals. So we're going to be 6 million doctors and nurses short worldwide by the year 2030. It's very, very stark. We've got the reduced time allowed for medical visits because so many more people have been holding out and not during COVID, not going to their doctors, not being able to access people. There's a growing complexity of the disease. There's difficulty in achieving the relevant clinical targets. We published a publication on this. There's a growing burden of disease, both for the healthcare professional and the patient. So it's really important that this is somebody with diabetes lives with it 365 days a year. We've got the environmental issues that we've seen debated, but there's also the obesogenic and diabetogenic environments that we see playing across Europe, and increased socioeconomic inequalities. Against a background of this, no healthcare system can respond just by putting lots more doctors and nurses in front of the patient with diabetes. It's got to be a little bit more than that, not a little bit, much more than that. So we're looking today at the way forward, how AI, artificial intelligence, how new technologies can help support, how digital therapeutics can be made more prevalent, how it can be funded, how it can be regulated in Europe. And that's what we're going to talk about today. We've got a really interesting panel, a patient with diabetes. We've got somebody who treats him. We've also got from the OECD a much more helicopter view on how population health management and inequalities can be reduced. So I welcome you all to this webinar. I welcome you to keep advocating for people with diabetes. I welcome all the stuff that you've been doing in every country in Europe, and have a great year on the centenary of insulin. Bastian, back over to you.
Thank you, Niti, for opening the panel part. And as always here at IDF Europe, we represent the voice of the people with diabetes through our many member associations, of course. And today on this webinar, it is thus my great honor to welcome Javier Paul. Javier, you are a good friend of mine, a good friend of IDF Europe. You are a type 1 advocate at its best. You are, as I said, a digital health entrepreneur. Please tell us from your patient perspective, from that digital patient perspective, also how from your role, from your perspective, the digital technology and AI will change the self-management, because, you know, diabetes is self-management most of the time, 99.9% of the time. So I really look forward to hearing from you how you see digital changing that.
Thanks, Bastian, and thank you everybody for inviting me, particularly IDF Europe for having me on today. And it's great to be amongst friends and people pointed in the same direction, helping people with diabetes at such an important moment that we're at today. So about me, just quickly, I'm here to talk to you about diabetes, but my context with diabetes started in 1994, so a long time ago. So now I would consider myself a veteran, an old soul with diabetes, and I've worked with all the different technologies that have been around in that time period. When you have a mother like mine who you just heard from, you get thrown a lot of the technologies that are out there to try out, and you hear the latest that is out there in the world of technology. So it was always going to be fate that I would be involved in technology moving forward. So my context is I work in venture capital today. I live in the UK, but I've worked globally. I've had the great privilege to be able to live with my diabetes in places that people find it very challenging to live with diabetes. And I'll talk a little bit more about that later on. But what I'm going to do today is talk to you about four stories that changed my view in relation to digital when it comes to diabetes and health in general. So I was in a meeting, a Zoom meeting like this a few years ago, when we were asking young children recently diagnosed with diabetes, what is it like living with diabetes? And one particular comment stood out for me, and this was in 2019. And the comment that stood out for me was, it's really great, I'm basically a cyborg, which I think was a really interesting comment, because people, when you ask them that question, will naturally revert to, oh, it's really difficult, it's very hard, my life, I've got to make a lot of decisions, I've got a lot of burden on me mentally, it has an issue with my work. But actually this child went straight to, I get access to technologies that makes me actually really cool. And it made me think really carefully about how would I have answered that question when I was first diagnosed in 1994. And it really makes you think what's changed in that period. And I really have to focus on two main things when it comes to changes in technology. Changes in technology for me range from actually having something on one of these, having a device maybe in your pocket, but it also comes in how do people treat you. And so the biggest changes in technology that I've seen in that period of time were actually from how do the health systems that exist out there start to respond to using technology better. You'll hear from my own endocrinologist in a second about his own responses to this. But I think there is a very big community of people out there who are changing the way in which they treat people, understanding people as a whole human, but also contextualizing the data that's coming back to them. But we then ask people, how does that change? We then ask adults, what do you think now? So how do you live your life with diabetes? What's it like? When you ask adults that question, the brain goes to a very different place, and it goes into, well, I'm starting to be concerned with what's going to come in the future. And so there's a lot of digital tools out there focus on treatment now, but actually do a lot less for what's going to happen across time. And so I think we're starting to get into this age of being able to show data and information in such a way, such a personalized way, that allows you to really understand your health journeys. So that's my first big main theme when it comes to what's the future of digital health going to look like. It's going to be highly personalized. It's going to allow you to essentially see into the future, which I think is a really exciting prospect. But then comes on to my second story. My major second story is actually to tell you, when did my mindset change in relation to AI? The promise of AI has been around for the last few years. We've all known about it. And I think there's always been a slight letdown on the technologist side about AI being good, but just not there yet. But my mind was changed on this about 2 years ago. About 2 years ago, I began using a new set of technologies, a set of technologies I know, Bastian, you use. I know, Sufyan, you also use them as well. These are called the Open APS, or the loop systems. So these are pieces of technology designed by people who are living with the condition, who understand the context of how you live your life, and turning that into a digital tool that helps you to manage that. In the case of Loop, that is connecting your sensors and your pump to some form of brain that controls it and helps you to be able to manage your own blood sugars better. I was skeptical when I first went into this. I then was able to be brought into a community of people connected digitally to help guide you through turning on one of the most amazing pieces of technological advancement I've seen in the world today. And that's whether it's being developed by a corporate, whether it's being developed open source, it doesn't matter. This is one of the greatest technologies I've seen. When I then went to meet my doctor, my new doctor at that point in time, Dr. Hussain, I was able to then start using the systems which had then started coming to the mainstream. Which took some of the mental burden off me. And I think Dr. Hussain actually realized that at that point in time. So my mind got completely changed in relation to the promise of AI. When I look at my HbA1cs now, but when I just look at my general well-being compared to where I was in my early 20s, I could see a very, very strong difference. So the message number 2 for me on the future and the promise of digital health is we have tools today that are underutilized, that are starting to see their light of day, but need the support of the community, and need the support particularly of people who can get them out into the hands of more people. And that means globally, whether in Europe or outside, but also needs help from patients to be able to be generous with their data and generous with their time to be able to help others to be able to put these technologies forward. So that's story number 2. Story number 3 takes you into a different direction. Quite a few years ago, I visited Rwanda, a country in East Africa. So Rwanda, when I visited there, I was going with a very kind of clean slate of knowledge. I didn't have much knowledge on what was going to happen when I visited Rwanda, but I encountered one of the most responsive health systems out there. Rwanda went through a very terrible civil war, very terrible genocide, actually. And that led them to have a very clean slate in the country. They needed to build systems of care for people. And their response was to really hyper-localize and to give people in that system the tools to be able to support each other. And I think that really changed my own mindset when it came to how we use technology. They use technology really well in Rwanda, but it's not on a smartphone. It wasn't a drag and drop solution that said, I'm going to drop this technology from a different country and place it there, and then it's just going to work. This was localized to say we're going to use different pieces of technology that people use on the ground. We're going to personalize it to the people that will actually need to use it. And now more people have access to Rwanda, access to healthcare in Rwanda than have in most other African nations across the continent. And it's because of the focus that was given towards personalization and putting the patient at the center of what's happening. So that's the third major big point for me on what we can do and what's the promise of digital and AI is, yeah, the technology is important, but the people around you make the biggest difference. And those people that are supporting you, and those people, whether it is the formal system or the informal system, makes a very big difference. And so finally, my own story when it comes to diabetes changed very significantly when a piece of technology was introduced. But to illustrate that third point, I wanted to give you the reasons why that was so successful. One of the big ones being, my doctor called me multiple evenings across a 2 to 3 week period, telling me that they've looked at certain things, I should maybe change some of the settings. There was a hand-holding exercise by someone who knew what they were talking about, that had my trust already, that was able to take me through something and gave me the action, gave me the impetus that I needed to be able to change my own life and change my own diabetes and care. So for me, those are the big main points for me, Bastian, in terms of what do I see the promise of digital health as being. I see the promise of it being hyper-personalized. I see the promise of it being able to predict the future. But I also think that we really need to focus on who's delivering it, how are they delivering it, and with what tools do those people have to be able to support us.
Javier, thank you very much for this also very personal insights into your journey over the last many years living with diabetes and using different tools, different technology, but also mentioning the personalized care that you received through someone who is now joining our call, Sufyan Hussein, who is taking care of you personally in a very good way using these digital tools. I want to ask you, Sufyan, from your, I think Jay mentioned a couple of things, a couple of points. The most important for me was, he said, it brings me to the question of how do healthcare systems respond now that things are turning digital? And you are kind of on both sides of this. You live with diabetes yourself, so you could probably tell a very similar story to Jay, but you treat people with diabetes, including Jay. So you are part of the system that needs to respond. You have, as Jay was just telling, been doing that in a very, very personal way, using digital technologies. But of course, there's also a lot of talk, and you know very well about clinical inertia, about the overall system having difficulties to respond, and you could not probably treat all your patients in the same way as you have been treating this one person. So how is digital, how is AI maybe going to manage or help you manage a larger population? How is that playing out in your clinical everyday practice, and where do you hope this will go? These are kind of my lead into questions, and now I look forward to hearing from you. Sufyan Hussein, thank you for joining us.
Thanks so much for the lovely introduction, and thanks for the lovely mentions, Javier, as well, and the lovely talks that just preceded it. Hugely grateful for being invited to come and speak here. Just before I begin, a slight issue with trying to broadcast my slides. I think I confuse the situation by being on two different names. So I think once we get that, then I can get started. But I think in terms of what Bastian's just mentioned, this is actually, it is really important to understand how we can use the digital aspects in the best possible way. And I think what JV's highlighted is so important, that at the center of all these technologies and devices is the individual or the individuals who are living with it, and then those who are looking after to try and make best use of it. So I think, yeah, so in terms of just sharing the slides, I'm just trying to understand where the technical side is. I'm disabled at the moment. It says host disabled participant screen sharing. So if the IDF team want to broadcast that, that's absolutely fine.
Slides are coming up now.
Excellent, thank you so much. So that's brilliant, thank you, and thanks again for the invite. So next slide, please. And these are my disclosures. And just to mention, like as JV said, I'm also an old soul in diabetes, having lived it for 30 years, so bring a slightly different perspective into it, alongside being a healthcare professional who's actively involved in managing type 1 diabetes as well as type 2 diabetes and using diabetes technologies in the adult setting. Nitty's mentioned the problem, which is a huge one globally, and now also for Europe as well, that it's just stark when you look at the figures. And as Nitty's mentioned, 6 million is going to be the shortage of doctors by 2030. And if you take into account nurses and dietitians, even more so. And when you look at the spending and expenditure, it is huge. And in addition to that, something that I've seen a lot, especially now in the last year, is the obesogenic environment that Niti's mentioned as well. It's got worse with COVID, with the fact that we're working more in a lockdown situation, we've been more sedentary. I've certainly seen a lot more diabetes, type 2 diabetes emerging in my own practice. So of course, the numbers are there just to remind us of the stark reality of the situation and why we need to act. Next slide, please. And sorry, this last figure here, just representing also the age demographic and age burden for this, predominantly looking at type 2 diabetes. And it's certainly important when we're starting to think about digital interfaces, because digital literacy for the individual using them becomes really important. And that's where we come in, because we have to train individuals how to make best use of the digital devices. So that's something that's a reminder here of the problem, the huge scale of it, why we need to act now, and the huge cost as well that's going to be coming to us, and how we can then potentially look at other ways of delivering healthcare that may improve the situation. Next slide, please. So I think this is just on the right, is to highlight where we are and where we're trying to move towards. So this is from 2015, the old landscape of the individual as a patient going to multiple different places to get their care, and that being a very inefficient way, but also a very resource intensive way when you take into account there just aren't enough healthcare professionals or healthcare establishments to look after the number of patients that's growing, and the complexity of these cases is growing as well. So the right slide shows you a slightly different approach of trying to deliver and enable the right care at the right place, the right time, with the right person being delivered, a more efficient care. I do have a slight issue with this slide. I feel the consumer, the patient, should be at the center and the rest should be around it, but that's fine, just to illustrate the potential of where we're trying to move towards, and where therefore things such as the digital aspects of delivering care come in. So I've got some, sorry, next slide, next clicks, please. If you go back, sorry. The AI and device therefore become key enablers in this particular journey, but to really try and harness its potential, we have to work with the individuals living with the condition, as well as those who are delivering care. And I'll give you some snippets of examples of how that is coming into play, and some of the issues that have also emerged in this setting and how we can overcome them. So next slide, please. So of course, this is a very broad topic of thinking about how digital technologies and AI can support decision-making and personalized diabetes care. Of course, when we think about technologies, we have to take into account other things such as remote ways of delivering care, video consultations, video follow-ups. JV has already mentioned, myself calling him as a way, of course, now we're transitioning to a more video-based way of delivering care. And in diabetes, that's been a very big aspect that we've worked on in the last year. The fact that we have data to look at, we can share screens, deliver education side by side, as well as doing our appointments. But just to put some issues out there from an operational perspective, firstly is that, from a time perspective, it doesn't actually save workforce time, but what it does do is help us deliver care better to the individual who might be at home. So their journey is reduced and the number of visits may be reduced to the hospital. So it's just to put out some of the aspects across there. And then the next click, please. So it certainly can help reduce operational cost savings. And next click. But there are some barriers as well. So we did a national survey in the UK, which is due to be published. Some of the barriers to effective remote consultations, and one of them was access to patient device data, because we're still not quite fully there. We're in a world where everyone has a device or a blood glucose monitor, or a way in which their glucose data and insulin data can go into a cloud system that the healthcare professional can look at. So that is a big problem. And the next one, as you can see it there, is patient familiarity with technology. And as I alluded to earlier, we've got obviously an age spread, and with that comes in aspects related to digital literacy. I'm not suggesting that that's always a rule, but just as one factor. Also socioeconomic status and health literacy, which also means that the individual's ability to use video clinics becomes less so. I do community clinics where I go out to practices and I see people, and often their socioeconomic status and ethnicity in the UK is much lower, and their ability to use video becomes less. And that's where we as healthcare professionals have to work with platforms that are easy to use, but try and train them how best to do that. So there is great potential, but there's some work to be done to make this more mainstream. Next slide, please. Just another example of how in diabetes we're using other ways of delivering care. This is from gestational diabetes. So diabetes that develops during pregnancy. These individuals traditionally needed 2 weekly reviews by their diabetes educator, their nurse, or the dietitian to look at the device data, to look at the blood glucose data and understand what to do. The platforms that we've been using in our own clinic, which rely on a meter that communicates via Bluetooth to the cloud. And we have a sophisticated platform that allows us to look at the data and message the individual. So again, also for us as clinicians means we're not wasting too much time in phone call, in checking the ID, in missing patients who may not be able to answer the phone or videos even. And in doing so, it's a lot more efficient and a lot more responsive. And built into that is also algorithms now that will trigger alerts to the clinician so we can orientate and triage things a lot more efficiently. So just an example of how we're using some of the digital platforms as integrated with ways of looking and reviewing the data and algorithms to come up with being more efficient. There's still a lot more work to be done. This is just one of the few examples that I had. So next slide, please. Well, then moving on to something that's very, very interesting, which is around how you can use more deep learning or more sophisticated ways of artificial intelligence, machine learning, to try and improve and deliver more efficient diabetes care. In this example, we have diabetes retinal screening. This is usually done on an annual basis every year, and in some people even more frequently, up to every 3 months, where an individual has to go to a clinic, has to have their eyes dilated, sit behind a camera, take a picture, then a clinician sees it, decides what to do. They may need treatment, they may need injections, they may need laser surgery, and this is really important to prevent their vision being compromised and losing their vision from diabetes. So this is a very comprehensive program in the UK, and what it relied on is individuals looking at the actual pictures to try and make some sense of what happens to the patient. But now we're in an era that we can use AI, ways in which we can train machines to look at the images and come up with a very accurate way of grading them to improve that decision making and to make it more efficient, so you have less involvement of the individual, of people or health resources, and target things more efficiently. However, these AI methods do require clean data. I mean, in IT, something I learned when I was very young: garbage in, garbage out. And what we have in the healthcare system is lots of silos of information and lots of gaps that don't lend itself very well to AI. And what we had here in the retinal screening was a very good ecosystem of clean data. And similar to what Jay there mentioned, where we have other ecosystems as well, we have very clean data where AI can make a difference. And that's something where us as clinicians can really understand how best and where best AI can work. Next slide, please. There's other aspects of technologies I don't have too much time to discuss, so just a few clicks. JV has already mentioned some, but we've got flash glucose monitoring that's really revolutionized diabetes care. We've got insulin pumps and glucose sensors now that they can also even talk to each other, as I will discuss, as well as smart pens that link via either near-field communication or Bluetooth to a mobile device. And on board, you can then configure a dosing advisor that may be able to link in the data from the glucose meter or glucose monitor. Next slide, please. But can these devices improve outcomes? This is the data from the United States registry. Now, as you're segmented into 3 different age groups: less than 13, 13 to 26, and greater than 26. As you see, as you apply more technology from injections and blood glucose monitoring to pumps, or injections with a glucose sensor, or pumps with a sensor, you can see that actually there's a stepwise improvement in glucose outcomes. However, if you look at the final endpoint of the outcomes, even though there's an ongoing improvement, it's still not quite good enough. And that's exactly the same reason JV's talked about it. It's a 24/7 continuous condition. This is type 1 diabetes, where you have to intensively manage your condition all the time. And this is where automation comes in. If we move to the next slide, please. And this was, highlighted many years back. It's been many years in the making, where DIY systems perhaps led the revolution and brought this really to the forefront. But we now have even commercial systems that allow this form of treatment. And this is simply where glucose is measured with a sensor that goes through a cloud-based system where it can be reviewed, but even locally, it can go to your phone or you can go to your pump. And the pump will then determine, or the smartphone computer will determine through an algorithm the dose that's required to adjust the glucose. So we'll use the glucose and adjust the insulin in a very responsive fashion, taking away a lot of that burden, improving outcomes. Of course, it still is a hybrid system, require the individual to still do things and some settings that need to be tweaked, hence my call to JV to try and adjust some of the parameters around it. So it still needs a clinician to guide and train the user how to use these systems. Next slide, please. So that's really been, I think, a big game changer in the type 1 diabetes management. There's also been the big breakthroughs around other aspects, one of which I'll talk very briefly, but equally also very recently, we've also published an international consensus on open source automated insulin delivery or hybrid closed loop systems, really spelling out that these DIY systems are ethical and safe to use and recommend in the clinic. And that's something that we want to see, a culture that grows of how citizen science and patient-centered innovations, but really at the forefront of technology, are approved by clinicians, by regulatory bodies, so it's so there are no blocks in the way of people being able to access what's good for their care. Next slide, please. This is just an example in type 2 diabetes, because I know it focuses a lot of the technologies around type 1. This is an individual with type 2 on dialysis. So, where the kidneys are not working, they're on a dialysis machine. This is actually a very complex situation to manage with insulin. On the left graph, it doesn't show it very well, but I hope you can agree that the sugars are high. And if you go into the daily data, it is crazy. This is a system that's now been engineered in Cambridge, which can be used in type 2 diabetes and recently published to show that it can improve outcomes in this very complex situation. The same sort of system that we've talked about earlier, and a system where it's linked to a sensor and a pump with a smartphone algorithm on board. And that means that the individual's sugars can stay in range more of the time with less complications, with less hospitalizations due to high or low sugars. The next 2 clicks will probably show you some examples of the daily detail and what the algorithm is doing in the background. I won't have too much time, I'm afraid, but it just shows you the adjustments that this smartphone computer is making every 5 to 15 minutes to adjust the insulin. Next slide, please. And if you just click a few times, sorry, apologies. The animations are never easy to use when they're not used by yourself. So this is just to highlight, one of the issues around technologies. Obviously one of them is cost, they're expensive, but also something that even in the NHS, in the National Health Service in the UK, where we have a supposed free to access healthcare, we still notice stark differences in access, which vary according to ethnicity, which vary according to deprivation. So if you're from a lower socioeconomic group, or you're from an ethnic minority group, you're less likely to be able to access the technologies, even though you're on a free healthcare system. And that's because it requires health literacy, as well as some element of digital literacy to use them. And it actually stems from something that was published almost 50 years ago called the Inverse Care Law, where more expensive treatments and the treatments that are really needed to those who are not doing well are less likely to make their way to them. And in the UK, we certainly see that outcomes from those from low socioeconomic groups and from ethnic minorities are much worse than others for both forms of diabetes, type 1 and type 2. But that's something that we need to try and understand and how we address. Next slide, please. And just a few clicks, if you don't mind, the slide. Yeah, so just to highlight before I close, I know time is short, but certainly accessing digital literacy and access is a key priority when you look at this issue globally. We've talked about some very expensive technologies. These artificial pancreas systems cost in pounds about £4,000 to set up, and roughly that sort of cost at an operational level, about £2,000 to £3,000 every year. So they are expensive, but how do we develop much more cheaper ways of using the technologies that we can also apply to developing countries with type 2? And there's some of the ideas around using non-invasive glucose monitoring, lower cost sensors, disposable patch pumps that are much lower in cost, or equally how you can use blood glucose meter and sensor data that can be then coupled with a dosing advisor and a smart pen to deliver a lower cost digital ecosystem that might help the user to get better outcomes. So I think I'm almost on my final slide. Apologies, the time has gone a little bit out of hand with the slide issues, but the future is really about how we can combine the digital technologies for the individual living with a condition to try and make their life easier, but also deliver aspects of their care that traditionally require them to come to hospital and make that easier. And on the right is one example of where the future could take us. So what I talked about with digital screening could be done at the individual's home with a smartphone, who knows? And that could be coupled with AI to deliver something in a much more efficient way, a much more patient-centered way. And the second aspect is working with the care systems to understand how we can use the data to predict and guide better and more efficient clinical decision-making, and a few other examples that I don't have time to discuss. So I'm really sorry about the slides and that I've gone over time, but I'll close things right here, and then very happy to join into the questions after the talks are finished.
Sufyan, thank you very much for this extensive talk. You covered a lot of ground, starting with remote monitoring of people living with diabetes to what you were just having also on the last slide, again, improved decision-making in your clinical practice where AI and tech might help you, to the tools that are out there right now that get this data to you, serving the population. And there's two things that struck my mind, and I'm sure we're going to get to this in the discussion. There's a couple of questions already in the chat as well. One is in the beginning, when you talked about remote monitoring, you said it won't maybe save time, but my personal experience has always been that it makes the little time we have between me as a person living with and my endocrinologist much more valuable. And the second point you covered was, or the last point you covered was the cost, and that relates back to the topic of today's webinar, the access issue. And I hope this is something where Luke will now address it from his perspective as a decision maker, because cost is of course something that decision makers have to take into account. And from a person living with diabetes perspective, we always push for these costs being seen as investment and not cost, because the outcome, of course, in the long run is what will hopefully make it all worthwhile. So Luke, I would like to welcome you now to this panel discussion, and from your perspective as a change maker specializing in e-health digital transformation, how does digital technology and AI change population health management for diabetes care from a decision maker perspective? Luke, thank you for joining us.
Thank you, Bastian, and hello everybody. It's an honor to be with you. I just want to clarify that I'm a former official with the OECD. I'm now working with them as a consultant, and which means that the views that I express are my own. They may align with a little bit with the organization, but not necessarily all the time. My background is clinical, and I since then became a policy analyst and health economist, and I have worked quite a bit on the topic of digital transformation health and managing health data with the OECD. So next slide, please. I will go quite quickly through the material and we can expand during the discussion, but first things first, as Niti said, I bring the helicopter view, the international viewpoint, the most removed from the clinic. And that can seem arcane and abstract perhaps, but it's important to constantly keep front of mind that everything is still about the people who need the care, who have or could potentially have diabetes. And I always try to keep that front of mind when doing this sort of work. Next slide, please. So a good place to start is just to take stock of how digital technology has been used in other industries. And while, of course, there has been disruption and it hasn't always worked out for the best, the overall effect in aggregate terms has been, without a doubt, a massive consumer surplus in a variety of industries. And the lifeblood of this transformation, as has been hinted at by Javier and Safjan, is data, our data, electronic data. Slide, please. So in health, the possibilities, because health is a very information-intense industry, are quite immense, really, when you really think about it, when you really imagine what could be done. So researchers can now predict when and for what a person will be admitted to the emergency room, just based on their Google browsing history. And there's some really fancy data mining and decision support work happening in the field of diabetes, as we've just heard. And we could go even further. Imagine if we could link not just medical or administrative data, but also people's shopping through their supermarket loyalty cards, or even the contents of their fridge once fridges become connected to the internet, which we keep hearing about. This type of information, if used securely and well, can definitely improve outcomes and improve and save costs along the entire care cycle, from prediction, prevention to management and treatment. Next slide, please. But the gap between what's happening in the labs and what's happening on the ground is a little bit like what we see on the catwalks of Paris and Milan compared to what we see people wearing on the street. There's very little similarity. Next slide, please. Earlier this year, we published a working paper looking at what's commonly referred to as artificial intelligence in health. And aside from the fact that really what in most, in fact, in all cases, we're talking about some probabilistic models like regression, fitting of curves rather than actual intelligence. But that aside, we really did find that the hype around machine learning isn't even close to being matched in everyday practice. And sure, there's some impressive examples, but we see very little scaling, and programs are beset by trivial glitches. So, for example, in an algorithm designed to read X-ray films was completely confused when the little logo, the hospital logo in the corner of the film, was changed to another hospital. It completely fell apart. So the main problem is that data are generally of very poor quality, that they're incomplete, that they're unrepresentative of the populations we are trying to measure and create predictive models for, and that it really is often a case of garbage in, garbage out. As Safjan mentioned, there is a real need for a clean data ecosystem. So the shining examples we have require a lot of careful data cleaning and curation before an algorithm can be trained on them. And that means that they're generally not transferable to a population other than the data set they were trained on, which obviously is a huge limitation if we're talking about scaling and cost saving and all those wonderful things that digital technology is known for, very small marginal costs. Next slide, please. So the fundamental problem is that health systems are awash with data, but these data are often poor quality. They're held in silos that are inaccessible, and they're definitely not used to their full potential. And that's the finding of the report we published in 2019, which was called Health in the 21st Century. Next slide, please. So the next few are going to be quite quick, a lot of information, but the main messages I think will be clear. So for example, it's no secret that linking microdata or patient level data can answer some very important questions for researchers, for policymakers. So we're talking about secondary use of data here, not the primary use of data for clinical care. But out of 23 countries responding to a recent survey, while quite a few link the usual suspect data, including registries and mortality, for example, and that's great. But the real interesting stuff from a policy and public health perspective is near the bottom of this slide or this chart. It's about matching with people's incomes, risk factors, their household circumstances. And unfortunately, such linkage is still done rarely. Next slide, please. EMR data are starting to be used for some interesting things like monitoring patient safety, but again, less so for the really juicy predictive stuff that we're discussing today. Next slide, please. So turning specifically to diabetes, the survey results suggest that while diabetes registries exist in most countries, they only cover the entire population in half of cases. So only cardiovascular disease registries have less penetration than the diabetes ones. And especially if you want to compare them to cancer registries seem to be far more advanced based on the responses to the survey. Next slide, please. In terms of regular data linkage, of the data that are available, even if they're incomplete, it's a similar story. Again, only patient experience data are linked less frequently than the data in diabetes registries. Next slide, please. Oh, I think we skipped one, but anyway, there's very little sharing internationally as well, according to the survey. So not only is the availability, accessibility, and coverage of the key data assets highly variable across OECD countries, so too are the frameworks for health data governance. And governance is principally about three things: security of the data, interoperability and quality of the data, and trust. Next slide, please. So it's little wonder that the health sector is lagging so far behind, because essentially we've built Tesla cars, but haven't bothered to update our horse and cart era infrastructure. And this includes equipping people with the capabilities, the knowledge to use these tools, these technologies. And this is where I found Javier's comments really interesting, about technology being nothing without people. This is so true, except I would also add from my helicopter position that technology is also wasted without having the right institutions to enable us to make the most of them, and particularly of the data that are so much now flowing through our economies, our societies, and our health systems. Next slide, please. But just to make sure we don't get too depressed about the state of things in this context, we are seeing some green shoots. So another survey focusing on electronic medical records suggests that countries are finally realizing the critical importance of common data formats, languages, and interoperability. And not just to improve care quality directly at the level of the individual patient, but to enable that much more valuable secondary knowledge to be generated from these rich data and information that we have. Next slide, please. So going back briefly to registries, one problem with registries is, of course, that building and maintaining them can be quite labor intensive and costly. So New Zealand has come up with a way, has automated this process. And New Zealand populates their diabetes registry, which covers their entire population, by harvesting the relevant patient-level data from 9 separate sources, including inpatient admission data, prescribing, primary care, pathology, and so on. All those silos you see there are connected by data trains, and the relevant information pulled out of them securely to populate the diabetes registry, which is then used for research and for monitoring, etc. Next slide. So closer to home for you, it's great to see the Commission's work towards a European health data space as part of its digital single market strategy. And again, it's not just to enable smoother cross-border exchange of patient data for healthcare purposes, for direct purposes, but to open a massive, massive pool of data and information. We're talking about 500 million people, to researchers in Europe and across the world to develop new algorithms, new technologies, new ways of making healthcare better and cheaper, so driving value. And the pillars of this initiative are governance, data governance. Next slide, please. And it's really great to also see projects such as BIRO, the best information through regional outcomes, which can not only lead to better prevention and better treatment of people with diabetes, type 1 and 2, but it will also be incredibly useful for research, analysis, and other knowledge that makes health system better and more sustainable. And perhaps starting to address some of those problems we were seeing on the earlier results of those surveys. So to sum up, and I realize I have gone very quickly, but to give us plenty of time for discussion, the electronic data and digital technology we have has massive potential, but it's held back by a lack of progress within and across countries regarding a good way of managing and governing these data. So I'll leave it there, and I look forward to the discussion. Thank you.
Luke, thank you very much for this very comprehensive overview. I do like that this is kind of a counterweight to, we heard a lot about the hopes that Sufyan and Jay were expressing, the hopes and the applications of digital solutions in diabetes care that we already see right now, but seeing from you the kind of roadblocks and barriers for scaling this up in a more larger context, I think it's very important to be aware of, especially as we're here talking about policymaking. And Marisa, I hope you are still there, and I would like the others, Sufyan and Jay, to also join us now for the panel discussion and turn on your camera, and Niti, of course, you as well. Marisa, if you're still there, if we could maybe link what Luke was just saying, the need for clean data, for better data governance to be able to work on population health management. How would you respond to that in the context of the European health data space? And I'm not quite sure whether, because Marisa Matias, I think, has to go to another meeting in the European Parliament. Maybe I could call on Sirpa. Sirpa, are you here already? Could you jump in? Sirpa is the co-chair of the MMD interest group. There she is. Sirpa, if you listen to Luke's presentation on the complexities around data governance and how difficult it is to actually scale things up, how would you relate to that when it comes to what's happening right now in the European Parliament across the European health data space that you are also working on?
Well, thank you. And first of all, thank you for excellent introductions. And I think it's a very good combination, because we need to look at the patient's perspective and the accessibility and the usability of the data. There are two ends, and then the other end is maybe the governmental needs to plan, for example, how many doctors and places and so on. And the third aspect is the science and research, what we heard about. And certainly this is a bit to task for one individual member state. So I think that this should be done in European level. And this should be part of this European data space. So it is the design access portal for research and science in one end. And there you could then the linkage, for example, what are the patterns of the person moving, using transportation, whether they have pets and what they eat and whether they exercise in gym. As said, this kind of a livelihood patterns and gene information, of course, is going to be abundant information to find new solutions. But then again, the governmental thing is a totally different thing, be it European or national level. I don't want my government to know how many cats or whether I'm regular visitor in a gym or not. But they need another kind of information about how many visits to doctors, how stable or unstable my treatment levels are, and all that to decide a proper healthcare system. And then again is, of course, what kind of equipment I do need, and it needs to be easily accessible. And this I just want to underline for those elderly, less educated people that need the device. So it would need to be very simple, user-friendly, so that I can use it, I can install it, I can understand it, and I can revisit it easily to get the information. Okay, then the whole question, and actually I'm now, Bastian and others, rolling the ball back to you, was the things that I was taking a note for myself for questions is, okay, how we create that kind of an interoperable system? Should we link it to a diabetes reference center that I hope that we will have in future? How tight connection it should have? Of course it should. This is much look to you to the other diseases and understanding that linkage. And so EU could be the sort of the funder and the host, but how to create that big model? Should we do it together with WHO or OECD, or what is the modeling in that level? And last but not least is then, of course, and as you can hear, very excited and positive in this, but then the question is the security, the data security, how we can sort of secure that cyber security, that your insulin pumps are not tweaked, because you could use that as a part of very unfriendly attacks towards the people as well. Sorry for consuming your time, but a lot of things to people on our table to work on.
No, thank you, Sirpa. I think it's important we link these different perspectives together and also have you come in then from the policy-making perspective in the European Parliament. But Luke, I saw you raised your hand. You want to comment directly on one of the questions that Sirpa was raising?
Yes, if I may, thank you. So I know Sirpa's from Finland, and if you looked carefully, you would have seen that Finland is a very, very high performer in terms of the coverage of the population of their data, but also the data accessibility and its governance. And you've recently created this marvelous system called FinData, which is a repository of various data sources that are accessible for research, and it's linked to your Kanta, your national personal health record. And it was interesting to hear you talk about trust and social license, because to use data for secondary purposes and to share it, and for the government to have access to it, because from what I've seen, and I've spoken to a lot of people in a lot of different countries, Finland is probably the most trusting population of its government in this regard. Finland, Estonia, the Nordic countries are definitely much more trusting than some of the other countries. But Netherlands, for example, people there just do not trust their health data to anybody. They would rather carry their information on a piece of paper in a file or on a CD between providers than have their data sort of flow digitally between to where it's needed. But what my other point I wanted to say to when you were talking about security. People often think that in order to do all this wonderful stuff with health data, they all need to be held in the same place. They don't. So data can be federated. They can stay securely in wherever they are held, whether it's a hospital EMR or it's a national statistical office, or even a primary care practitioner's EMR platform. But if they are all coded according to agreed international standards, then it's possible for other clinicians or other providers and the patients, of course, themselves to access these data wherever they may be without them ever having to leave their secure location. So I just thought I'd make that point straight away. It doesn't have to be a trade-off between using data and security. We can achieve both through good, solid, thought-through health data governance. Thank you.
That's governance, and that's the need. What you were saying, Luke, about clean data, that it's coded similarly so that the different systems can talk to each other. Jay, I saw your hand went up when the word trust was mentioned. Do you trust your data to go from A to B in order to make these larger systems work? Would be a question I'd have for you.
Yeah, it's an interesting one, because when I look at it on a personal level, as an individual, I really don't have any problem with trusting my data to move around, because I actually don't mind anyone seeing it in reality, because I personally don't have any issue around anyone seeing my data and making a judgment on me in that sense, because I gave up that hang up a long time ago in my own head. I think at a group level, I think there's a very different mindset, and I think at a group level, and this is where the personalization point makes a very big difference. It is down to the individual on how comfortable you feel. Systems can do some things to make themselves more trustworthy to individuals, but I think there is still a very difficult large group of people that's very hard to get them to trust the system in any way, shape, or form. So we have to have a system that can deal with both types. That's my personal view on how systems orientate. But one thing I did want to kind of pull the conversation slightly in a different direction was to talk about what's my responsibility as an individual citizen within this whole system. And my responsibility as an individual citizen is also to take control of my own data myself. And so, a great example of this in the UK was around people donating their data to make a change towards flash glucose systems being prescribed in the country, across the country. People donated their own data, showing that it worked really well. And then that got taken up by the system to say, we can then go out and centrally commission this. And it was a really good example of people donating their own data to see an outcome or a change that they want to see. And Sofiane, I'm sure, can talk a lot about what the Open Project is doing in terms, and you can as well, Bastian, in terms of people giving their own data towards an outcome. And that generates a lot of trust when it's given towards an outcome, and you see that outcome happen, and you make that small win become a bigger win and a bigger win and a bigger win. People then start to trust a lot more, and then I'll give you my data willingly. I'll personally give it to you. I'll create a server for you and give it to you. So that's my own personal view in how to bring the patient and individual responsibility. But I'd love to hear other people's thoughts.
Yes, and Sofiane, you raised your hand as well. You wanted to come in. Please go ahead.
Yeah, so it's just echoing what's been mentioned earlier. It's a very, very interesting topic, and I think certainly, the aspect of sharing the data, I agree with Joe there that, at an individual level, I don't see any issues as long as the data is anonymized when it's pulled together. And that's when, it can be used centrally. And there are excellent examples of that in the UK with the National Health Service. We have something called the NHS number, which makes it like what's happening in Finland, makes it your ability to identify individuals and use that data. But as long as it's anonymized when it's passed on, and that's when you're making your population health decisions or financial decisions or government-based policy decisions, that's what you want. You're not looking at JV as individual data, but as a population health level to understand what's happening. So at least to take that side away, just to make that clear. And I think when we're talking about interoperability, I think this is a huge and very important topic. There really needs to be a lot more push towards standards. And I think several aspects to this. One is at the individual patient level. I'm sure, Bastian, you agree with this as well, and Jay there as well, that we want to make sure the devices we use are interoperable and where the data can be shared with the apps that we may want to use. There's some question around, sleep tracking apps. And yeah, we want them. We want them all to work and play together. And when you look at the DIY movement, that's what enables it. But when you look at the commercial side of things, that's where data gets locked in. So we want to see those interoperability standards being conformed to. In the clinical world, I want to see that too. There's a platform that was mentioned in the chat at Dyson. Yes, it works with most things except for one of the company's main pumps, so we can't use it for everything. We want those barriers being removed so we can review the data in the portals that we can see, and the individual can still use whatever device or whatever app they want to use. But as long as they all work to standard, the portal that I view it at can suck that data in, and then I can still see it the way and train my nurses to see it the same way. So they're not looking at 5 different platforms and learning how to do things separately. So there's interoperability standards are very important. I think something like the European Parliament would be very, very key to this, because they could hold industry to account to ensure that the blood glucose meters, ensure that the sensors, ensure the devices, ensure that even the EHR, because that's where interoperability comes in as well, all speak the same common language. And I think, those the other points I absolutely agree with. We're sort of, in the UK, we've found it very difficult to move to an integrated health record system for multiple reasons. There's probably the biggest IT disaster in the world, which is the BT one, almost 10 billion, because it just showed how difficult this situation is. We have lots of small pockets of integration of healthcare records, but when you scale it up, it becomes harder. And I think Luke will know more about this field than I do, but just wanted to highlight those things from my perspective.
So I would just, we are unfortunately almost running out of time because we had so great presentations. But what we've done so far is we've heard a lot from Jay in the beginning about how digital and digital tools have changed his self-management in diabetes care. And then we heard from you, Sufyan, about how it changed clinical decision-making and how it enables you to be better in giving personalized advice to your population, to the patients you serve. And then Luke took it towards the population health management level and talked a lot about what's currently not yet working or what the needs are. So as we have Sirpa here on the call, and if this is as this is directed also towards policymakers, I wonder from your 3 perspectives, what would be the key messages that an organization like IDF Europe, and Niti is still here, that an organization like IDF Europe should bring forward towards the European Health Parliament, towards the European Parliament to work on these things? And Niti, you should probably take note about what's coming. Jay, if I start with you from the self-management perspective, what would be one of the key messages you think the IDF organization should bring forward?
Really good question. I mean, on the spot, I would probably say that everybody should make sure all the stakeholders are at the table when these conversations are happening around what are those standards, what's the way in which we should develop these systems, because blanket policy making or blanket decision making won't be the way that this stuff gets nested properly. It won't work in practice if people aren't on board into it. So true representation of all the stakeholders, I mean industry, I mean pharma, I mean IDF Europe, and patient organizations and patients themselves, would make a very big difference to the way in which we can actually bring standards to people in a way where they're not feeling forced to deliver upon them, where actually there's the buy-in is already there. So I would make sure that all those stakeholders are at the table would be my big takeaway.
And Sufyan, from your perspective in the hospital, to overcome the clinical inertia when it comes to changing systems, making sure they're all interoperable, what would actually help you?
I think, similar to what JV has mentioned, is having those sharing protocols, interoperability standards, an open API type approach where you're not locked into one provider. That is key, and for the individual, for the health system as well, because that helps with innovation and helps to drive creativity as well.
And Luke, I love your, putting the finger to where it really hurts, and that much of this is currently not yet happening, but that it actually doesn't mean data has to be all centralized. It can stay where it is and still be safe. How could IDF Europe push this call forward? As I think there's also maybe a lack of understanding sometimes amongst policymakers on how this digital world actually works. Are you hopeful we will be able to achieve this in the near future with the European Health Data Space, for example?
I think so. I think I completely agree with Jay's and Sufyan's comments about making sure that everybody sits around the table when these decisions and these discussions are had, and that interoperability, I think, is probably the most key, the most pressing technical and stakeholder issue. But beyond that, I think I think countries and governments and institutions are realizing what the potential is and what the barriers are, and there's a general shift moving towards that. But I would actually say something completely different, which we haven't really mentioned yet, and that is the critical importance of collecting patient-reported outcomes data from patients periodically. patients with chronic diseases like diabetes, type 1 and 2, it's just so valuable to have the results of their care measured objectively through, there's a range of instruments that can be used. They're all validated. And if these can start to be plugged into electronic medical records and registries, and then it really enables us to evaluate the effectiveness of some of these technologies that we've been discussing, and then also calculate the value, the cost effectiveness of them. And then you can really start to have the discussion about, hey, you can get so many QALYs or avoid so many premature deaths by implementing some of this stuff, and that will make the decision makers sit up and take more notice. So patient-reported outcome measures in parallel to all this is critical.
Thank you, Luke. And this is exactly what I was referring to when I was talking to you earlier about taking the focus maybe away from the cost aspect to seeing investment into health as investment. If you don't know the outcome, which you can measure through PROs, then it's hard to do that.
Yeah,
Niti, I hope you take note of the many calls here. I'll have to skip you due to time and move straight to Sirpa. Sirpa, when you're hearing this, how would you wrap it up, and what of this discussion can you include in your daily work on European health data space and other activities on the European Parliament level?
Well, this was a very good, excellent discussion, and reaffirming the fact that we need a European health data space. We need the interoperability. I'm sorry. We need the patient-centered focus. We need to think forward on creating that kind of a system that actually enables the personalized health care to all of our patients, and especially in diabetes and among other NCDs where the sort of a scale matters. And we need to collect the information back from there. Okay, then a couple of questions that I would like to leave you with, not to answer now, but knowing that IDF is a great worker and you are great specialists. One, and I'm still coming back with the data security. I'm not afraid of the EU or Finnish government, but there are quite a number of governments that I really wouldn't want to have my or yours personal data, especially if it would include sexual preferences or ethnic knowledge or like that. So that's why I'm just sort of referring to that kind of a use, like the blockchains in the future, because EU can finance that kind of initiatives. Should we be the first ones to say, look, this is the way how we should think the next steps forward in data. Then the second question actually is how this data could be used better in prevention, on early analysis, and gathering the different sort of traces, tracks of the diabetes, or personalizing the care. And then please create that kind of a model what we can really present to all decision makers, and to make all of us aware that this is needed because of the patients, but this is needed because there are so many pressures, as you staggeringly showed in beginning for the healthcare system. And that didn't even include the climate change and its extra load for our health systems sustainability. And if we do not act now and quickly, we will be late. So please give your advice. Please organize these seminars. Please create that kind of a roadmap how to get there on Diabetes Care 2.2. Thank you for excellent meeting and discussions.
And thank you, Sirpa. And that was actually the call out, or the topic even, of today's event. If not now, when, right? We have to act now if you want to make these digital technologies accessible to everyone. Thank you to everybody. I have to apologize to the audience. There were a number of questions in the chat, but we will record those and hope to include them in the final report and reach out to the speakers so that we can answer some of those there. And with that, I would like to hand over to Nebosa, Vice President of IDF Europe, for his closing remarks. Thank you to all the speakers. Thank you to everyone who was here. And Nebosa, please take it away with the closing remarks. Thank you. Goodbye.
Thanks, Bastian. Thanks, Bastian. Am I? Yes. Okay. You can hear me, I hope. We are now at the turn of the century, if you wish, of diabetes care. We spent the first 100 years, and we are now starting another 100 years of diabetes care. I mean, from the discovery of insulin, but that was in fact the beginning of the modern diabetes care. The second century appears to be starting with the digital technologies rather rapidly coming into diabetes care. And what was important from this webinar is that the main principle of those digital technologies should be that they need the personal needs, they should be personalized. And it seems like slightly difficult because we went through different problems. But on the other hand, if you look to the first syringes that were used after the discovery of insulin and the syringes that are used now, you can see that there are a lot of opportunities. And if you just have a brief look onto the advancement in digital technologies in the last couple of years in the field of diabetes, it is really amazing what can be done. So in that context, I do think that we can share a cautious optimism, but a lot has to be done and initiated in not only IDF Europe, but also other organizations that were so kind to participate in this webinar. Thank you very much. Thank you to everybody. And let's see each other at another occasion to verify all this.